All right, welcome everybody to one of the TCTAP wrap-up interview sessions. My name is Nils Johnson from the University of Texas in Houston, and my co-moderator here is Jung-Min from Asan Medical Center. We have three people who are joining us for the interviews: Dr. Nico Pijls from the Netherlands, Dr. Bill Fearon from California in the US, and Dr. Bon-Kwon, also here from Seoul National University Hospital. And what I'd like to do, Nico, if I could, is to lead off with you. Obviously, FFR, something you developed, and you've seen all the trials over the years. And I was taken with your talk today about criticizing, or at least getting some insight into FFR trials. And I wondered if one of the challenges, perhaps, is that FFR is a diagnostic test. It's not a drug, it's not a device. Do we need to be thinking about designing diagnostic trials in a different way in order that we get meaningful results out of the end? You know, you talked about how FAME, I think, was really designed well and gave very clinical, meaningful answers. And that wasn't maybe as clear from some of these other studies. Is it because we're dealing with a test and not a device? Or I don't know, what's your thought on that?
Yeah, well, my personal thought is that in fact in the last 25, 30 years, we tested almost everything we could test in FFR. And of course, after a while, there came FFR was initially meant for intermediate single lesions. It expanded to all kinds of coronary disease, even for diffuse disease and for focal and diffuse disease together. We have developed pressure pullback recordings, which we did already 20 years ago with hyperemia. Then with IFR, we also learned about resting pullback. And Carlos Collet and his colleagues invented the PPG index to make that even better. But fundamentally, I think that all the FFR trials have been done and are convincing. The problem is indeed that people should apply it. You cannot expect that it should be used in everybody. That is what one of you already discussed earlier this afternoon. If you have single vessel disease, a positive exercise test and complaints, you do not need to do in FFR. But especially in multi-vessel disease, it will be very helpful. The trial I would like to see still is a trial comparing FFR and the non-hyperemic index in really high-risk patients. I tell that because in the defined FLAIR and the Sweetheart study, only very low risk patients were included. And in these patients' outcome, whatever test you are doing, will be good anyway. And in addition, in the defined FLAIR study, in fact, that was not a physiology-guided study, because in the IFR-FFR group, in 50%, first, visualization was done, and if by visual estimation the lesion was lower than 30 or more than 70%, there was no physiology done at all. So I think that in that respect, it would be very helpful to have a study like FAME with real severely or moderately high-risk patients in whom these tests would be compared.
Idea for FAME 4.
FAME 4, yes.
Nico touching the concept of FFR and FFR trial designs. I'd like to ask you, Dr. Gu. The last year, Dr. Gu published the flavor trial in New England Journal of Medicine. Congratulations. So I think this study is very important because this study designed to answer the simple question. If we have one modality, imaging or the FFR, which modality we can use for the decision for revascularization? Is it right? Can you summarize your study and how to apply your result to the clinical practice?
Yes, thank you for asking that question. So that some are saying that flavor is comparing apples and oranges. IVUS FFR, what's the meaning of comparison imaging and physiology? But we thought when we designed this trial, we were thinking about the patient vulnerability, which can be defined by the hemodynamic significance, luminant narrowing, plaque burden, plaque characteristics, as well as the PCI optimization and PCI needed. So in that very whole perspective, the question is image-based anatomy and vulnerability concept versus physiology concept for revascularization decision and optimization of stenting. So that we have two different criteria for revascularization and also optimization criteria, either by physiology and anatomy. So the results were quite simple. There were no difference in clinical event, no difference in patient quality of life, but FFR reduced the number of stents significantly. So you may already expected that according to the design, but there are several concepts that the imaging guidance PCI should be much better than physiology-guided PCI, and the vulnerability, so-called plaque burden or plaque characteristics-based treatment without ischemia may improve the prognosis, but our study is showing that if you choose one, especially for intermediate stenosis from decision-making to optimization, physiology may be superior to the imaging guidance.
Yeah, if I can just ask a question too, does this go against, I mean, a number of studies have shown the benefit of imaging guidance. Do we apply that more to the complex lesions, or like one could argue that the IVUS group should have done better because they had the optimization?
Yes, if we have a longer lesion. So the question is, maybe Nico already mentioned this, and Nils always mentioned this, so that if we apply physiology as you've shown in FAME3 trial, in a 90% stenosis, very long diffuse calcified lesions, that trial will be failed. But that's not fail. That's a failure of application of wrong devices in the wrong patient. So that we have to interpret this kind of a, so I learned a lot from Nico's presentation, so that there is a different meaning or different hierarchy of the results according to the study design, so that answer can be, that question can be answered in the design and how we can apply this device in this specific situation.
Well, and leading into your stuff on FAME3, Bill, I know you can't give us the data that you're going to show at EuroPCR in a couple weeks, but as I've seen the CABG PCR trials, CABG versus PCI trials over the years, what's seen in the first year sometimes doesn't always predict what's going to happen at 3 or even out to 5 years. And that's been, I think, clear from some of the meta-analyses that the curves take a little bit of time maybe to diverge, that CABG is a therapy that takes time for the benefits to accrue. What are the kind of expectations, or what have you built into the follow-up of FAME3 to try to figure that out in the longer term?
Yeah, so as a reminder, FAME3 is comparing FFR-guided PCI with CABG, and we presented the 1-year results, and FAME3 did not meet the criterion for non-inferiority when you look at death, MI, stroke, or repeat revascularization. Most of that was driven by increase in repeat revascularization at 1 year, although there was slight, not statistical trend, but numerical difference in MI also. But stroke and death were not at all different. And when you look at stroke, MI, and death at 1 year, they weren't different either. The key difference in FAME3, I think, compared to previous studies is that the event rates were better in both groups. Both PCI and CABG did much better than compared with Syntax. And I think that's a very important lesson. And the difference between the two groups was much less than it had been, in, for example, in the Syntax trial. So we'll be presenting the 3-year outcomes. Frederick Zimmerman will present that at EuroPCR, and the main endpoint is the incidence of death, MI, or stroke. So getting rid of repeat revascularization, as many people view that as a less important endpoint currently. And these will be very interesting data. We're going to follow patients out to 5 years as well. And I think what will be interesting is to see if the very low death rate and the very similar death rate that we've seen at 1 year, if that continues at 3 years and 5 years. I would imagine that the MI rate will probably continue to get a little more different. I mean, Jung-Min saw that in the BEST trial with current generation DES. So our hope, though, is that maybe having incorporated FFR, the difference will be less, because FFR, I think, helps reduce MI compared to angio-guided PCI. So that's sort of my guess, but obviously we'll see what happens.
And probably a lot of the strokes are front-loaded too, right? You either have a stroke during aortic manipulation during CABG, or you have a stroke during your PCI, and so the first month or something, they've all happened, and then the next 4 whatever years, it's
similar,
whatever the background rate is for patients who have coronary disease. Yeah, Nico.
Yeah, I would even like to add something. people consider the FAME3 study as a kind of negative study. But in fact, if you look at the data, they are impressive. The rate of events in both the PCI group and the cabbage group is twice as low as in the syntax study in comparable patients. What is the difference between the studies? 10 years of time, maybe better stents, and FFR guidance. I cannot tell which of these three is the most important, but it is impressive to see that in 10 years' time, in patients with an average syntax score of 26 or 29, we have decreased, both with PCI and with cabbage, the rate of event by 50%. Yeah. It is an impressive study, I would say.
Great.
So I would like to ask to Nico again. You changed your playground. I mean that the FFR is a target for coronary physiology for epicardial coronary arteries.
Yes.
I just find that nowadays you play in the ground of microvascular vascularity, is
yes.
right? Yes. You may Monday you may cover some microvascular evaluation, the absolute flow and resistance measurement. So could you introduce us that what is how to apply in your practice?
It's not only my playground, but the playground of half of the world that changed. And we more and more realize the importance of microvascular disease. In fact, in the last 20 years, by IVUS, OCT, FFR, we learned everything about the physiology of epicardial arteries. Yeah. Still, the microvasculature is in fact the black box. Yeah. We have IFR, we have CFR, but both methods, and I do not want to offend Bill, are rather crude and inaccurate. The absolute flow methodology with absolute resistance in milliliter per minute and Wood units is extremely accurate with an unsurpassed reproducibility and completely operator independent. And that allows us, together with a regular FFR measurement, to calculate absolute flow reserve, but also an index we call MRR, microvascular resistance reserve. And in my view, this MRR will be for the microvasculature what FFR is for the epicardial. And indeed, we have a symposium on Monday afternoon at the Coronary Theatre, and there we will have the opportunity to tell more about that. And we also have there a live case from Aalst in Belgium, performed by Bernard.
I'm very looking forward.
Very good.
Kwon, I want to ask you a question about some of the QFR stuff. You've been involved in a lot of angiographic-derived functional index metrics, be it FFRCT or other things. And we heard the data that Dr. Bourjou presented about Flavor 3 China. Do you see, after maybe the results from Flavor 3 in Europe and Japan, if those are not inferior, maybe the FAST 3 trial or some of these other ones that are coming along, are we going to see people shift from wire physiology to angio-based physiology? Is that what your expectation is?
I think there should be some shift if you have a more and more positive results, but I personally think that my practice wouldn't be changed that much, so that I should say. But if we have more data, but the one thing I know for sure is that what kind of image we are using, angio, IVUS, OCT, CT, we cannot reach 90-95%. That's natural because we cannot extrapolate the individual physiology from the average value of hyperemic flow increase, etc., etc. And we know the angiographic limitation very well and CT limitation very well, so that it can be used as a kind of a gatekeeper for physiology. If angio FFR is 0.95, so it's fine. 6.6, it's fine. But we are using physiology in the cath lab, not for FFR 0.95, not for FFR 0.66, for 0.7 to 0.85, etc. So if we really want to have that kind of narrow range of precision, I think we still should stick to the invasive physiology rather than image-based physiology. But one good thing for image-based physiology is it can provide many other elements, such as PPG can be very easily calculated by any image-based physiology, and other rather complicated indices can be automatically calculated. But we need to see whether that kind of additional extra information can overcome that kind of 20% deficit. So we need more data for that.
I agree with Kwon, but I will say that I think he's a true expert and an academician and a scientist, and so he sees the gold standard and wants to use that. I was wrong when non-hyperemic pressure ratios and IFR came along. I was like, well, I'm not going to use that. I don't think anyone will. You still want the gold standard. And now, at least in the United States, the majority of cases are done with non-hyperemic pressure ratio and not with FFR. And so I wonder if the same thing will happen with the angio. I think people who just want to get an answer and say that they did it and aren't as dedicated to the gold standard will shift over, because I envision that it's going to be quicker and easier and less risk than doing a wire-based approach.
I have one more.
I also agree with both of you, but because of practical reasons, if I do an invasive exam anyway, it takes 2 minutes to put a pressure wire in and to have the true FFR. Why not doing it? It would become interesting if you have a real good FFR assessment truly non-invasively by CT. And that will be the case in the future. So I think that will really become very interesting. And we talked about the microvasculature. This MRR is fundamentally also to be derived from CT. So I think in 10 years from now, we will use a CT with FFR CT and MRR CT for our diagnostic part of the procedures. And then we go inside, we will be invasive for therapeutics. So.
Okay, the Bill. I like more specific coronary physiology. Nowadays, we did a lot of TAVR cases. Severe aortic stenosis and coronary artery disease share the common pathophysiology. So at least 50% of patients who underwent TAVR had the coronary artery stenosis. So how to evaluate it physiologically in your practice?
Sorry.
Go ahead.
No.
Oh, was it to me?
Two of you.
Yeah. Go ahead, Bill.
I think the number of issues to consider with severe aortic stenosis when you're thinking about FFR, there can be microvascular dysfunction, and so you might get a higher FFR initially across an intermediate lesion, and then when you relieve the aortic stenosis, there may be less microvascular dysfunction, and also you've relieved sort of a proximal stenosis, so to speak. So there may be a better flow across a vessel or a lesion and the lower FFR. With IFR, or the non-hyperemic pressure ratios, you have a lot of hemodynamic changes before and after relief of aortic stenosis, and that can change resting flow, and so you can get sort of the reverse, where you have a low IFR and then it gets higher. And there have been a number of studies that have compared physiology before and after TAVR and have shown these changes. Fortunately, the changes are small, and these are in intermediate lesions. And so in my opinion, I do TAVR, and these intermediate lesions, I think most of them, the aortic stenosis is really the key prognostic factor, and you need to relieve that. And then you can reassess the coronary disease down the road, depending on how the patient's doing and responding. And I don't actually measure physiology that much. It's only if it's a really tight lesion that I'll revascularize, and if it's a moderate, I'm more focused on the aortic stenosis.
Yeah, this is, I think, a very practical point.
Well, if I could, in the last moments here, Jung-Min, take the prerogative to ask you a little bit about one of the studies that you at SON are carrying out. And we've talked about low FFR and revascularizing, but what about lesions that are FFR negative but have other high-risk features, right? TICFAs on imaging or a large plaque burden. And there's a lot of interest in plaque sealing or in preventive PCI. There's a big study that you guys are doing called PREVENT. Maybe tell us a little bit about that and when we can see some results.
Yes, last session, Antonio asked us that how to treat or not. If there is FFR is negative, but the imaging showed a very vulnerable plaque. So I think our PREVENT trial can answer to his questions. PREVENT trial is to test the preventive PCI on vulnerable plaque. Vulnerable plaque defined by the imaging criteria. So in patients with FFR negative, but the imaging show that the vulnerable plaque, we randomly assign to the two groups preventive PCI using BVS initially and later the Giants and optimal medical treatment alone. our target population was 1,600 population. We already complete the patient, the enrollment, and the last patient will be follow up complete the 2-year follow up this September and October. So I think we can answer such questions next ACC meeting. We plan to the leg bracket trial presentation at the next ACC meeting. So,
all right. Well, hey, I'm looking forward to it. That's a wrap. Thank you so much for your time. Enjoy the meeting, everybody.